We are starting here in this Shaukat Sadikot Hall our first innovation program. So we have already with us Dr. Professor Azad Khan, who is chairing this session. Can I have, Dr. Azad Khan and Dr. S.R. Arvind, who are there? Can I have their slide? So we know that Professor A.K. Azad Khan is a currently chair-elect for Diabetes IDF Southeast Asia region. Currently, we have chair is Dr. Shashank Joshi, and Dr. Azad Khan is professor of diabetology, and he is also the chair-elect for IDF Southeast Asia region. He is from Bangladesh. He is also FRCP and FCPS. Professor Azad Khan is a very senior diabetologist, and along with him, we have with us Dr. S.R. Arvind, who is President of Diabetes India. He is Director and Chief Diabetologist of Diacon Hospital, Bangalore, India. Now over to them for our first session.
Thank you, Dr. Banshi, and it's a pleasure to be sharing this.
Can I add something? Banshi has introduced me, but he has said the most important thing, that I'm a friend of Banshi and Shashank.
Thank you, sir. Thank you.
Thank you for being there for us, Dr. Azad Khan. And I think to take this, the first session going, I think I'll request Dr. Azad Khan to take over from here, and I'll always be there at the back to support him. So he will be the main chair for this particular first session, which is a virtual meet. Over to you, Dr. Azad Khan. I request all others to mute so that there's going to be no disturbance, please. I request. Sir, you
remote call. I would like to humbly request you to continue chairmanship. I'm with you. I'm in a very remote corner of Bengal. I'm in the south, quite near the sea. So I will be with you, but please continue chairing.
Okay.
Thank you.
May I request the RX events to come out with the program, the first program, and then to start off. Do we have the speakers or are they recorded lectures?
So Arvind, Inas is the first speaker, and you can introduce her, and then we can.
Is Dr. Inas live, or is it a recorded lecture, please?
Recorded lecture is there.
Live, sir.
Okay, she's live. Okay. Welcome, Dr. Inas Shalaut, and she's a professor of internal medicine and diabetes from the Cairo University. She's been the chairman of Unit 4 Internal Medicine Department at the Cairo University. She's the president of the Arabic Association for the Study of Diabetes and Metabolism. She's the honorary tutor of diabetes at the Cardiff University, member of the European Association for Study of Diabetes, Egyptian Society of Internal Medicine, Egyptian Society of Nephrology, Egyptian Society of Diabetes, and Egyptian Medical Association for Studying Obesity. And I welcome Dr. Inas Shalaut, and then she will be starting her first lecture now. I mean, I don't see the faces on this virtual platform, so I don't have a speaker's view here, and it's a gallery view. So may I request the RX events to show Dr. Inas live, please. Yeah, she has just been introduced.
Sir, Dr. Inas' talk is live, and I think ma'am is not joined.
Has she joined?
Can we move on for second talk? Dr. Rayaz sir is joined.
Absolutely fine, and I think we can follow that up with the lecture of Dr. Inas. We'll move to the second one, and okay. So I think what we'll do is by the time Dr. Inas actually comes on live, I would like to start the first talk of Dr. Rayaz Malik, who is the professor of medicine at Qatar, Vale Cornell Medicine. He is the Associate Editor of Scientific Report, PLOS One, Frontiers Endocrinology and Frontiers Neurology. Welcome, Dr. Rayaz.
Thank you.
Can I see your live video there? Yes, I can see your live video, sir. So thank you so very much for joining us, and I'm sure it's going to be pretty early over there. And You will be talking about the diabetic triopathy, and that's going to be a very interesting first talk. The stage is all yours, sir.
Thank you and good morning. And thank you to the, of course, the organizers, Dr. Shabu and the chairpersons. So the talk that I've been asked to give is on the diabetic triopathy. So it's an update on really the management of the three major diabetes complications. And these, of course, are retinopathy, nephropathy, and neuropathy. But if anybody knows anything about me, then you will know that neuropathy is my area of expertise and interest. So unlike other speakers who would start with retinopathy at the top and then nephropathy and finally remember a little bit about neuropathy, I will start with neuropathy. In terms of neuropathy, I think it's important to remember that the risk factors for diabetic neuropathy are not simply glycemic control. And this is a key paper from now over 16 years ago, which Solomon Tesfaye published in the New England Journal of Medicine, where they showed that the risk factors for diabetic neuropathy, that is damage to the peripheral nerves, is very much I would say a vascular complication, because hypertension actually was the biggest risk factor. And then also other cardiovascular risk factors like being overweight, like having higher triglycerides and higher total cholesterol were contributing as much towards diabetic neuropathy as glucose control. And actually, with that comes a Cochrane review, which looked at the benefits of enhanced glycemic control in terms of outcomes in trials in both type 1 and type 2 diabetes. And what did they show? Well, they showed that in type 1 diabetes, predominantly driven by the DCCT, that improving glucose control improves neuropathy. However, in type 2 diabetes, and these were studies which included the Accord study, the UKPDS, part of the UKPDS, and VADT study, there was actually no significant difference. And people, when they looked at this data, they thought it can't be true. And I think it is true, but it's because of reasons. And the two reasons were, I believe now, one, that the therapies that were being used at that time in patients with type 2 diabetes were not good enough or didn't have a targeted effect on the nerves. And two, the way they measured neuropathy in the two different trials was different. That in type 1 diabetes, they used highly sensitive tests like nerve conduction. In the type 2 trials, they actually used very, very rough and ready tests like clinical examination, monofilament examination. So that's part of the reason. And actually, then something happened about 2018 as a sub-study of the liraglutide LEADER trial. There was, I would say, tenuous evidence, but nevertheless, there was something to suggest that GLP-1 therapy might have an impact on diabetic neuropathy. So first of all, actually, they looked at the incidence of foot ulceration, and they showed no difference between liraglutide and placebo, about the same over the period of 5 years. However, when they looked at, of course, the dreaded outcome of diabetic neuropathy, which is amputation, and this is Mr. von Bergmann from Berlin, 1901, what they showed is that there was a signal, statistically significant, in terms of people who had foot ulcers going on to have amputations was reduced in those who were on GLP-1 therapy compared to placebo. Of course, placebo wasn't complete placebo because these people were also being treated with standard therapy, suggesting that there may be an impact of GLP-1 therapy. Now, subsequently, in Qatar, we actually were part of a trial called the Qatar study, where essentially poorly controlled patients with type 2 diabetes with average HbA1cs of 10.5% were randomized to either GLP-1 once weekly exenatide with pioglitazone or basal bolus insulin. And we looked at the impact on neuropathy. And first of all, what you see here is that there is no difference between what we call combination therapy with the GLP-1 combined with pioglitazone and or basal bolus insulin. So both were effective in lowering HbA1c from around 10.5% to 7%. However, instead of using monofilament neurological examination, we actually used a very sensitive technique that we've developed over the years called corneal confocal microscopy, which is a rapid test that allows you to image small nerve fibers in the cornea, but is a surrogate marker of nerve fibers elsewhere. And what we were able to show effectively within 12 months was the following, that actually compared to healthy controls, you see here, these white lines are the nerve fibers. In both the GLP-1 and pioglitazone arm and the basal bolus insulin arm, there was actually repair of nerve fibers over 1 year, showing that actually a number of things you can measure in terms of these nerve fibers, so fiber density, branch density, fiber length, all improved significantly in actually both arms. But if you look to vibration perception, really in one arm it improved, in the other arm it didn't. So there was a kind of, it was just not good enough as a test. Then other risk factors, as I noted at the beginning, hypertension is an important risk factor for neuropathy. So this is an old study, but has been actually replicated by a number of studies subsequently, where we showed that if you give patients who are normotensive without microalbuminuria an ACE inhibitor, then if you measure nerve conductions, you can see that there is within 12 months an improvement in motor nerve conduction velocity, M-wave amplitude, and F-wave latency, indicating that treatment of people with normal blood pressure improves neuropathy. There is also a study, again coming back to vascular risk factors, a small study from Mexico, which compared rosuvastatin with placebo and showed that in the people treated with rosuvastatin, there was a significant improvement in nerve conduction velocity, perineal nerve conduction velocity of almost, well, actually 2 meters per second. The other measures didn't really change. Amplitude almost became significant, but nevertheless, there is some impact in a small study. And probably the most impressive data actually comes from the field study, where it was seen during the field study, which is a very large randomized trial in type 2 diabetes, where the cardiovascular outcomes were negative, but the incidence of minor amputation, you can see, was almost 50% reduced in people on fenofibrate compared to placebo. And that again suggests that there is an impact on neuropathy. And if we look at the other aspect of neuropathy, which of course is painful neuropathy, then what we have are data from the UK, the USA, which show that 1 in 5 individuals have painful diabetic neuropathy. This is a large study that we did in Manchester in the Northwest region of 15,000 patients in secondary and primary care. And we established a prevalence of 1 in 5 patients with type 2, predominantly diabetes, have painful neuropathy. However, if we look closer to the region that I'm currently working in Qatar, actually, we've done almost a similar study where in 1,171 patients with predominantly type 2 diabetes, we've shown a much higher prevalence of 34% as opposed to 21%. And particularly along with the Qatari Arabs themselves, the prevalence was even higher. And so we asked the question, why is the prevalence higher in this region, and why is it particularly higher in the Arabs? Well, part of the reason is because we've established that obesity is a major risk factor for painful diabetic neuropathy, alongside smoking as well. But the traditional risk factors like HbA1c, hypertension, for painful neuropathy, there is no risk. But the other thing that we showed, unfortunately, is that the majority of these patients who we diagnosed with painful diabetic neuropathy had not previously been diagnosed or treated. And that again shows that as physicians, we're not looking for painful diabetic neuropathy in 80% of these patients. In terms of choices of therapy, well, not much has really changed because not much has really come onto the market in terms of new therapies. So we still have the established therapies like pregabalin, gabapentin, or the SNRIs like duloxetine and venlafaxine, and of course the cheaper alternatives, which are the tricyclic antidepressants, but they do come with side effects. So according to the ADA, you can use either of these therapies, or you can switch to another agent if one isn't working, or use combinations, lower doses of combinations. Of course, pregabalin and duloxetine were approved in 2004. Subsequently, there have been two other approvals. One is tapentadol, which is the mu receptor agonist and partial works on descending inhibitory pathways, which is a cousin of tramadol, and that may be used. And most recently, the FDA has approved the 8% Quatenza, which is the capsaicin 8% patch for diabetic neuropathy. I must say, I have my reservations about this because I think this is not something that I would be putting on the feet of people with diabetes, because there are data to suggest that high dose capsaicin may in fact inflict damage to the small nerve fibers. The other thing that you might or I would want you to do is actually check the vitamin D levels in these patients, because what we and others have shown is that patients with painful diabetic neuropathy have lower levels of circulating 25-hydroxy-D compared to patients with painless diabetic neuropathy and healthy controls. And in fact, the level, if it's less than 20 nanograms per mil, there was a 9.8-fold increased risk of painful diabetic neuropathy. And if you had a level less than 30, it was 4.4-fold increase. And we showed this in Manchester, but in Sheffield, Solomon Tesfaye's group showed exactly the same. Lower levels predict a diabetic painful neuropathy. And we, of course, previously, in collaboration with the Bakai Center in Karachi, did a controlled trial where we gave D3 600,000 international units intramuscularly, followed up over 20 weeks, and we showed a significant improvement in 3 different types of pain scores. But interestingly, the average level of 25-hydroxy-D in these patients was actually what one would say is relatively high. That is 31 nanograms per mil. And most people wouldn't treat this, but when we did treat it, you can see it went up to 46, and there was an improvement. The other aspect, of course, is erectile dysfunction. The ADA would want you to screen annually for erectile dysfunction with simple questions in the consultation. In terms of endocrinology, one should not in every patient with diabetes, because obviously sometimes it's obvious, but if you have somebody who's got, say, mild diabetic neuropathy, then assess the LH testosterone. And if the testosterone is less than 12 nanomoles per liter, then there is data to suggest that you get a benefit by treating with testosterone. The other thing you ought to do is advise patients to stop smoking, because ED improves by 25% if you stop smoking. And then, of course, we know there is a standard set of therapies, and there's nothing new here. PDE5 inhibitors are, of course, very, very effective, and there are different types, and you can give them daily as opposed to weekly. Statins also improve the erectile dysfunction score, and then you have other alternatives. In terms of retinopathy, basically, there are really, again, pharmacological approaches for retinopathy are glycemic control from the Accord study, where there was, as you can see, an improvement compared to the standard arm with the HbA1c of 7 to 7.9% compared to 6%. There was a significant reduction in the progression of diabetic retinopathy by 33%. And again, the fenofibrate story continues in that actually what people on fenofibrate in the Accord study had a 40% reduction in progression of diabetic retinopathy. Glucose control, interestingly, which people most think ACE inhibitors, ARBs are effective retinopathy, didn't show a benefit in the Accord therapy. And of course, in the field study, there were, if you looked at macular edema, proliferative retinopathy, and all retinopathy, there was a significant signal for people on fenofibrate that prevented progression of diabetic retinopathy. And based on that, actually, fenofibrate has a license for retinopathy in Australia. More recently, there has been a really big database that's been assessed in terms of fenofibrate effect on vision-threatening retinopathy. This is comparing 144,000 people on not on fenofibrate compared to 5,000 on fenofibrate. HbA1c, interestingly, really reasonably well controlled. But what you see is the following, that vision-threatening diabetic retinopathy was reduced overall in multivariate analysis. You can see P is 0.01. And the predominant driver was the progression of proliferative diabetic retinopathy. You can see highly significant impact on the progression of proliferative diabetic retinopathy. They did assess for macular edema, and they did not find an effect. And that may be partly to do with how macular edema was measured in an insurance database, but nevertheless, they did not show an effect. So it seems to be not having as much of an impact on macular edema, unlike the field study where there was an impact on macular edema. In terms of nephropathy, of course, we have lots of people always think about lowering blood pressure in nephropathy has an impact. And there are many drugs that we can use. But of course, remember that really ACE inhibitors and ARBs are the main drugs that should be used in diabetic nephropathy. But what do you do when, despite being on an ACE or an ARB, you have adequate blood pressure control and the proteinuria is continuing? And really, also remember that there are actually no drugs to date that have improved the GFR. I will talk about drugs that might have stabilized the GFR, but no drug to date has improved the GFR except a drug which came with a lot of promise, but unfortunately got pulled because of cardiovascular events, bardoxolone sodium, which was basically NRF2 inhibitor, which is an anti-inflammatory. So I think we need to wait. Maybe there is something coming around the corner for that. But if you don't have these additional drugs, if you're already on an ACE or an ARB, then there is evidence to show that spironolactone overall further reduces urinary albumin excretion rate by 30%. In both type 1 and type 2 diabetes. And this is old data, again, 15 years old. And there is a Cochrane analysis which looked at 27 studies, which shows that aldosterone antagonism has an impact. So we know that it has an impact in terms of heart failure, cardiac fibrosis, but also it is being shown to have an impact in terms of renal fibrosis and hypertension, and having an impact on CKD. And we not only have spironolactone, but we have eplerenone and finerenone. They again show no effect on progression of GFR or renal failure or dialysis, but what they show is an impact in patients who've got stage 1 to 3 CKD. If you add one of these antagonists, you reduce proteinuria by a further 0.61 grams and you reduce blood pressure. But of course, remember, look out for hyperkalemia, gynecomastia, and in women, postmenopausal women, bleeding. What next? If you're, despite on being on an ACE or an ARB, you're on spironolactone 25 milligrams, you've still got adequate blood pressure control, but proteinuria continues. Well, something old, really, for something new. So this is a recent paper published in the New England Journal of Medicine in 2021, where patients had chronic kidney disease, predominantly diabetes, had a reasonable control of systolic blood pressure. Estimated GFR actually was way down, 23. And they were randomized to chlorthalidone or not. And what they showed is that there was a further drop in systolic blood pressure on chlorthalidone, but which went after discontinuation actually came back up. And there was a drop in urine albumin excretion rate, further drop. And again, that came up after it stopped. And eGFR, although it dropped slightly from 24 to around 21, you can see it remained stable and then actually normalized again once chlorthalidone had been stopped. So ACE, ARB, spironolactone, chlorthalidone, what do you do if it continues the proteinuria? You still want to reduce the proteinuria. Well, there are two drugs now, classes of drugs actually, that have been shown to have an impact despite being on these current therapies for lowering blood pressure. And those are the GLP-1 agonists. So liraglutide in the LEADER study and semaglutide has also shown similar effect, where you can reduce progression actually of eGFR to less than 45, renal replacement, renal death. You can see here there is actually a 22% reduction in nephropathy in the LEADER study, but there is a small signal for retinopathy, which we ought to be aware of, which there are currently big randomized trials actually going on to have a look at this. And so far the signal is safe, and there isn't a worsening of retinopathy. Well, we're running out of options really, but there are options. So now we have one class of drugs, three different types of drugs, the SGLT2 inhibitors, which all show a further impact. So worsening nephropathy, you can see the EMPEREG study, reduction with empagliflozin. And the other thing, the key thing that we are now showing is that instead of this progression of GFR on the SGLT2 inhibitors, we can actually flatten out the GFR. So that's empagliflozin, canagliflozin has the same impact, renal specific outcomes reduced significantly, and a kind of flattening out of eGFR, certainly less progression of eGFR. And with dapagliflozin, actually we showed exactly the same effect. So SGLT2 inhibitors work effectively for diabetic nephropathy. Thank you.
Thank you. Thank you, Dr. Malik. I think, can you just close your slide, sir?
Yeah. Stop share.
Excuse me, I think I request RX to actually close this, because if there are any questions, all the three topics are not connected with each other. Maybe if there are any questions on the chat box, let me try to have the questions so that we can ask the questions to Dr. Malik and then go on to the next this one. Are there any questions? Okay, if there are no questions, I think as you can post the questions, I'll request Dr. Azad Khan to make some comments on this particular lecture by Dr. Malik, please.
Well, I thought it was an excellent lecture. So many new things, new possibilities. So I would like to congratulate the speaker for finishing on time and giving the information. Thank you.
Thank you.
Thank you, sir. With that comment, I just have a few questions to ask Dr. Malik. That was a brilliant lecture, Dr. Malik. But then you did mention about fenofibrate, which is being used a lot in the earlier studies. And we don't seem to be using fenofibrate all that much now, because it was almost a decade back that fenofibrate made all the noise that it actually helps in microvascular complications. What do you do in your practice? Do you use fenofibrate specifically aiming at microvascular complications?
I do, actually, because I read the data. And, I think the problem is that we as physicians, we go to statins as first line, and a lot of the companies push the statins and we forget. But fenofibrate, independent of lowering triglycerides, has been shown to have an impact on neuropathy. So it's not just a triglyceride lowering effect. So don't just think about it in a patient who's got high triglycerides. And there are other mechanisms of action of fenofibrate, because it's a PPAR alpha agonist. That help. And I do actually, in clinical practice, if I have a patient, particularly a patient who's referred to me for neuropathy, I put them on fibrates.
I mean, irrespective of the level of the triglyceride, you put them on fibrate? Okay.
Yes.
What is the normal dosage that you have been trying, Dr. Malik?
So it's 200 milligrams. There's a standard dose. I mean, and that's what was used in the fenofibrate trial. And that's the average that was used. It's not just neuropathy, actually. There is data, good data, and I didn't have the time, obviously for retinopathy. And there's also renal data, microalbuminuria data as well, that shows, so there is an impact of fenofibrate on microvascular complications.
Yeah, because most of the recommendations that we do hear from EASD and the ADA is use fenofibrate only when the triglyceride levels are more than 500, because the only threat you have is that of pancreatitis. Otherwise, fenofibrate has nothing else to do. But that was an interesting thing, you bringing back fenofibrate and microvascular complication, and especially neuropathy. Dr. Nigam, would you like to add anything at this point of time if you are listening to Dr. Malik's lecture? You are muted.
That was a brilliant lecture, but I would have probably, there are new data from dulaglutide and all the three GLP-1s, semaglutide, dulaglutide, with dulaglutide not having any retinal risk, as you mentioned, with semaglutide. And the SGLT2 inhibitors, I think, have taken the front seat in all the guidelines, suggesting that if you have chronic kidney disease or diabetic kidney disease, then probably without even not considering the baseline HbA1c or patients having risk factors also, I think the SGLT2 inhibitors and the GLP-1s will probably take the front seat and push all the other agents behind. And the SGLT2 inhibitors and the ACE inhibitors have very fine synergistic effects, one acting on the afferent arteriole, the other acting on the efferent arteriole. So I think they have taken that front seat when talking about diabetic kidney disease. And again, something that we notice in India, and I'm sure it's not anywhere in the world, is the use of unwarranted use of methylcobalamin with pregabalin. I think I just prescribed pregabalin, and that is the message that should go around, because you're unnecessarily increasing cost of therapy without knowing. If you have documented vitamin B12 deficiency, I think it's worthwhile adding that agent there. But otherwise, blanket prescriptions can probably have no benefit.
I mean, I agree with you, Nikam, on that. I think Dr. Malik's comments.
Well, you're right. SGLT2 inhibitors are coming, and they're going to have, and actually there are data now, published data, that show there's an impact on retinopathy. Of course, remember the SGLT2 inhibitors had this bad signal for amputation, particularly canagliflozin. But I think if you look at some small studies coming through, they also show that that's probably not a true signal.
Yes.
So that I think we should be reassured. In terms of GLP-1 therapy, there is again data showing a benefit possibly on retinopathy. Like you say, dulaglutide hasn't shown that signal. I think it was all to do with the endpoint. So there's a big trial with semaglutide, about 4,000 patients that have recruited, and they've seen no signal to date.
Yes.
Methylcobalamin, yes. Unfortunately, this is something that is a mythical thing that all doctors, particularly in Pakistan, India, Southeast Asia, even Middle East, they prescribe this, kind of amazing vitamin B compound, which is supposed to be health reparative, nerve reparative, and there's no real evidence for it. So I think what we need is studies to show that is the case, and then people.
That also has alpha lipoic acid, which probably works in parenteral doses and not in the doses that is administered in oral tablets.
I completely agree with you. Again, the evidence there for alpha lipoic acid was generated on IV administration, was never for oral, but yet again it's been pushed and people accept it. I think in India you have do you have an approval for alpha lipoic acid?
No.
I mean, not for this indication, but then there's an approval to give it to every other patient, whether he needs it or not, because that's exactly what happens, because the pharma company tends to push it and the doctors tend to buy the idea that it's extremely good for the nerves. And of course, it's a most frustrating experience for a patient who has a painful neuropathy. So all kinds of treatments are being tried. And the capsaicin ointments are pretty popular in some corners of India, and there's one set of patients who would love to have something to be rubbed on, especially at night when they have the painful neuropathy. And I think with that, thank you so very much, Dr. Malik.